My name is Shermis. I'm Medical Director of ProMedica Breast, a large breast imaging center in Toledo, Ohio. It's sort of the hub of all Metro Toledo breast imaging, where all these satellites and smaller hospitals in the Toledo area send their images to our breast care center. And we also deal with the diagnostic patients that come from those studies and who approach our breast care center with a problem.
My name is Dawn. I'm a nuclear medicine technologist for ProMedica Toledo Hospital. I spend half of my time in the main nuclear medicine department performing normal diagnostic testing. My other half of the time is spent down at the breast center doing molecular breast imaging.
The equipment and the resources at the breast care center are second to none, and the technologists are all subspecialized in breast imaging. Before we had the LumaGEM MBI system, we were basically stuck with a mammogram, even women who had a very dense mammogram, and that's a problem. We know on a dense mammogram we can't see as much as we want. We were very fearful of going down the screening breast ultrasound route because we knew it was fraught with a lot of problems. Our experience with target ultrasound even showed us that we were finding things that we didn't know how to manage and we didn't know what was important. This caused a lot of anxiety both on part of the patients and ourselves. We adopted the LumaGEM breast imaging system about 5 years ago, and since that time we've done over 5,000 examinations, and our volume is increasing every year. MBI has provided a lot of confidence. It's sort of our sweet spot study in our center. The negative predictive value is extremely good for MBI. It approaches that of 97 to 98%. So if a woman has a dense and very complex mammogram, it's hard to flush out what's going on with traditional imaging. MBI really answers that. We found that our breast surgeons really like MBI. It's an easy test to understand. The results are very helpful. Many are using it for preoperative staging or planning when MRI is not an option. As we gained more confidence in MBI, we decided that we would now use it as our primary supplemental screening for women with dense breast tissue who are not high risk. Basically, our workflow starts at a point where we have a mammogram that's normal but dense or complex, and we're uncomfortable with the fact that we might be missing something. The next thing we want to do is evaluate the patient's risk level, and if they're a high-risk patient, they're going to go on to breast MRI. We send a patient a letter recommending that breast MRI, and then we also make that recommendation on the report to the physician. Very specific, saying the mammogram is negative, but given the dense mammogram and the high risk level of the patient, breast MRI is recommended. And we will then follow up the letter and report with a phone call to both the patient and the physician. If the patient is not high risk, we're going to send them on to molecular breast imaging. Molecular breast imaging patients will get a letter very specific to that recommendation discussing their level of breast tissue density and a recommendation for adjunct imaging through molecular breast imaging. The patient's physician will also get a specific recommendation in the report, and then we'll also follow up that report and letter with a phone call to the physician and/or patient.
We have a lot of patients that do MBIs because they are not able to do an MRI, whether it be for some surgical procedure, claustrophobia, or just not able to tolerate it. We are up to doing 7 patients a day now, testing patients from screening to diagnostics through that dense breast tissue where otherwise things could potentially be missed on mammograms. After we explain to the patient why we are doing the test, we ask them to change. We give them warm blankets. We then give them the tracer injection. We explain to them there's no side effect. It's not going to cause them to feel anything different. After we've done flushing that through, we do pull the IV out so it's nothing that stays in them. We bring them into the imaging room. We do 4 7-minute pictures, CC view on each side and an MLO view. We explain to the patient that we're going to position them very similar to the mammogram but without nearly the compression. They're able to talk through the procedure or readjust their arms and legs if they need to, which kind of puts them at ease.
Setting up a mini hot lab for an MBI program is not a daunting task. It's actually fairly straightforward. The technical issues are not hard to deal with. And I would say that using your physicist and Gamma Medica to set up the lab is going to be an easy thing. It makes me feel great on one level because I know I'm providing a service very few other places have. On the other hand, I feel very frustrated that a lot of other people aren't doing this because it can fit in virtually into most practices without much effort at all. Before, we might have had to turn to MRI, which is much more expensive, time-consuming. But now, with MBI, we can do it rapidly and in a real-time fashion, and this provides a great environment for the woman to get her results quickly And if we have to do something, act on them quickly. It's much better tolerated, it's a lot faster workflow process, and our patients love it. MBI has had a significant impact on our local healthcare expenditures. We're doing far fewer unnecessary biopsies. Our false positive rates have really dropped a lot. The cancers we're catching with MBI are invasive, they're small, and they're node negative. And those are cancers that are much less expensive to treat. For those embarking on an MBI program, I would take two things to heart. It really works, and it makes breast imaging much more pleasant than if you're using screening breast ultrasound and even MRI. Those are complicated examinations to read. Going forward with the program, you're going to find it really easy to learn, very easy to use, and it's going to make your practice much better.